Okay.
Ultra running shoes help you stay comfortable and stay out there. With searching all along, you're facing twilight home. Without a sign, without grasping it, there will a question to be asked. Where have I'm a shapeshifter, outpost masquerade, hiding both face and night.
Okay. Making my way downtown, walking fast, faces faster than home, man. Do 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 do. Staring back ahead, making my way through the crowd.
Hi, you guys. So, what did we want to go over tonight? Everything for the final. Which final? Farm or Med Surge?
Med Surge.
Oh, yeah. Everything. Oh, my goodness. Okay. What topic did you guys most recently go over? The last thing was endocrine? Okay. Do we want to start with endocrine? Do we still want to start with cardiac? What do you guys want to do? Yeah, type it. Unmute yourself. Jessica says endo. Are we good with endo? You want to start with endo first? No preference. All right, let's do endocrine. Okay, 1732 I know we did a review for endocrine before. Did it help for the test? Like, was there more detail? Was there stuff that I was missing? Or was it a good review when we went over it? Okay. All right, then we will go through endocrine. Remember, the big boss is hypothalamus. You've got the pituitary, anterior, and posterior pituitary. Remember, the one that only has oxytocin and ADH is the posterior. So the anterior portion of the pituitary gland is in charge of all the other hormones. Let's see. For disorders of pituitary, there's either too much growth hormone or too little growth hormone. Too much of growth hormone, it's either before puberty or as an adult. If there's too much growth hormone and we're an adult, it's called acromegaly, right? Big hands, big face, pronounced jaw, maybe voice changes. If it's before puberty, it's gigantism, so before the growth plates fuse. So that's gigantism. This is like Yao Ming. When I see gigantism from my basketball fans, Yao Ming, he was on the Houston Rockets. He was like really long and tall and skinny. So everything looks proportionate. It's just bigger than their peers. So how do we treat either of these? Well, for acromegaly, the treatment is either going to be some medications, maybe some radiation, or even removing the pituitary tumor that might be causing it to kind of calm down the pituitary so it stops producing so much growth hormone. For gigantism, so too much growth hormone before puberty, the treatment is going to be either removing the tumor or radiation with the pituitary gland, and then replacing it with pituitary hormones that we can control. Okay, too little growth hormone is called dwarfism. This happens during childhood, so most people are born with. You'll identify dwarfism early on. The treatment is to replace the growth hormone. These are injections. Let's see. And they lead fairly average lives. Another disorder of the pituitary gland is diabetes insipidus. It's kind of coined the diabetes because it's very similar to diabetes mellitus symptoms. Those who have DI, diabetes insipidus, remember they have polyuria, polydipsia, so too much peeing and excessive thirst. So if we're peeing a lot, what does their urine look like? It's going to be very diluted, right? They're going to have an excessive urine output. And because of that, they're always thirsty because they're always trying to replenish the fluids that have been lost. We diagnose it with looking at their urine-specific gravity, actually measuring the antidiuretic hormone in their urine, in their blood. And then how do we treat it? We're going to give them desmopressin, DDAVP, or vasopressin. Remember that medication? So it's to help stop so much urination. These patients are on this medication for the rest of their life. Now, how about SIADH? So, syndrome of inappropriate antidiuretic hormone. We release too much ADH. So, what happens? We hold on to fluid. Too much antidiuretic means that we're not peeing enough. So, what does that patient look like? They look swollen, right? Their sodium level in their blood is very low. And what can that cause? That can cause seizures, nausea, vomiting, all that kind of stuff. How do we treat it? Well, we're going to restrict the fluids because we know that they're not peeing out. They're probably also going to be given a diuretic, like we've learned so far, like furosemide, to get rid of that excessive urine retention. But also, most of the reasons why they have SIADH is some type of tumor or cancer or disease with the pituitary gland. So most often, we're going to either remove the tumor surgically, radiation, even chemo. So for any type of SIADH or the DI, of course, we're going to monitor I's and O's, electrolyte balances, vital signs, level of consciousness. Any questions on those so far? Okay. And then for the next gland, we had the thyroid. Remember, we have hyperthyroidism and hypothyroidism. Hyperthyroidism means the thyroid is working way too hard, so the big boss, hypothalamus, doesn't have to send a lot of signals to the thyroid. That's where we're going to see a low TSH level. Hyperthyroidism has low TSH because the boss doesn't need to check in on them. How do we, what are the signs and symptoms of hyperthyroidism? It's going to be Graves' disease. Remember, exophthalmos with those big bulging eyes. We're going to have the big bulging eyes. Okay. Okay. And then to treat it, the treatment for hyperthyroidism is either PTU or methimazole. PT or methimazole. This is to decrease the output of the thyroid production so it can calm down. We may have to, and if it doesn't calm down, or if it's because of cancer that's causing the thyroid to act too quickly, we may have to do surgical removal, which will then put the patient in hypothyroidism. And then we have to supplement. If a patient has a thyroidectomy, so the thyroid is removed, one of the things you have to look out for is bleeding. In a thyroidectomy, you're not going to see blood like sitting on the throat. The blood can go around their neck and pool in the back of their neck. So it's very important to check, to lift the patient's head so that you can check underneath them against the pillow to make sure that they're not bleeding. Because it's so close to the throat, we're also thinking of airway. We're thinking of dysphagia. Okay. Another complication of a thyroidectomy is called the thyroid storm, right? So this is when you release a large amount of thyroid hormone into the bloodstream. Usually happens within 12 hours post-op. It's the same signs and symptoms of hyperthyroidism, just like on a scale from like 10 to 100. Like it's gone up way bad, including even a fever up to 106 degrees. But the treatment is still the same. We're going to give IV fluids to dilute the amount of thyroid hormone hanging around and give them the anti-thyroid drug, either PTU or methimazole. Now, for hypothyroidism, either you've born with it, you've developed it, or now you have hypothyroidism because of the thyroidectomy. It's the opposite. So with hypothyroidism, we're going to have high TSH, high thyroid stimulating hormone, because the thyroid is being very lazy and not doing its job. So it's getting a lot of emails from the hypothalamus, a lot of notifications from them. So what happens when you get a lot of messages? Your inbox builds up, right? Your spam folder builds up. That's where you get that goiter, that really enlarged thyroid, because it's just not producing like it should. It's being flooded with TSH. How do we treat hypothyroidism? We're going to give a medication called levothyroxine. This one is lifelong. It is safe during pregnancy. And even during pregnancy, we may have to increase the levothyroxine to support the development of the baby. There's also cancer of the thyroid. Cancer of the thyroid could be from a nodule. How do we treat it? We're going to do radiation, probably chemo, then more than likely a thyroidectomy. Any questions on thyroid? Okay. Did you guys go over, was there any test questions on hyper or hypoparathyroid?
Oh.
No.
Great. Okay, on to the next. How about Cushing's and Addison's disease?
Yes on Cushing's, no on Addison's.
Okay. All right. So Cushing's. What's going on with Cushing's? Well, this is an adrenal disorder. It's hyperfunction. What is going on in Cushing's syndrome? We have too much corticosteroids. So think of the C in Cushing's and relate it to corticosteroids. Too much cortisol. What does that look like? Moon face, acne, that buffalo hump behind the neck. There's a good picture of it in your big textbook, and I think it was one of the cartoon animations that I shared with you guys. How do we diagnose this? Well, we look at the ACTH hormone in the bloodstream. We can also take a CT scan of the adrenal glands to see if there's a possible tumor on there. How do we treat it? We're going to treat it by, usually, most of the time it's caused by a tumor, so we're going to remove the tumor. But Cushing syndrome can be caused by prolonged steroid use, like somebody who takes prednisone over a very long time. So we're going to have to gradually taper them off that steroid, and then they should, all those side effects of Cushing should resolve. If we have too much corticosteroids, remember it affects our immune system, right? So making sure that the patient stays healthy and away from other people. Yep, that's it for Cushing's. Did I miss anything for Cushing's? Okay. And then did you guys went over diabetes, right?
Yes.
Okay. So diabetes, there's two types plus gestational. Type 1 diabetes is usually, it used to be called juvenile onset because it was found it's usually something that's you're born with, but you're diagnosed like 2, 3, 4 years old, usually when that poor child has gone into DKA and is hospitalized. Those with type 1 diabetes, they're not producing any insulin, so we have to replenish it with insulin injections. Type 2 diabetes used to be adult onset, but unfortunately we're seeing it more and more younger and younger. This is usually due to like not enough insulin cells, or there's an error in the production of the insulin cells, or even a resistance to the insulin. This is because of too much blood sugar, obesity, that kind of stuff. So, first treatment for type 1, it's insulin, right? That's the only thing we need to replenish the insulin. Type 1 diabetics are not on any oral medicines, just insulin. Type 2 diabetes, we usually start with metformin, and then we add other oral medications, and then if it's still uncontrolled, then we move to insulins. You should know the signs and symptoms of hyperglycemia and hypoglycemia. Hyperglycemia looks like the 3 P's: polyuria, polydipsia, polyphagia. This is where somebody pees a lot, is really thirsty, and really hungry because their body's trying to replenish the sugar while urinating it out. The diabetic ketoacidosis, this is where you have a very scary high amount of sugar. This can put you into the coma. Type 2 diabetes, we promote weight loss, healthy eating. You should be familiar with what kind of foods they should avoid. So what I tell my patients is anything sweet you can think of, it's got sugar in it. But also bread, pasta, tortillas, rice, potatoes. So the carbs. For insulin, it can come in a variety of forms, but the insulin sites are all the same. If you're giving it on yourself, it should be in the abdominal area, upper aspect of the arm, or on the thighs. Most people who have to do insulin do it on their abdomen. It's the easiest place to reach.
Thank you.
There's different types of insulin. What's the one insulin that's cloudy?
NPH.
NPH. NPH is cloudy. All the other ones are clear. I'm trying to think of what other questions you guys might have about diabetes. Oh, the complications of diabetes include from head to toe retinopathy, so permanent damage to the retinal nerve and blood supply. It can cause increased infections and poor healing throughout the body. Causes damage to the heart, so heart disease, kidney failure, kidney disease, and then I think most commonly known like the neuropathy on the bottom, that usually it's the feet and the hands, so nerve pain. And then wounds on the feet that don't heal. Any questions about diabetes? Okay, what am I going over next? Cardiac? You guys want cardiac or renal?
Can you do both?
Yeah. Which one do you want me to do first? Cardiac? We can cardiac. Yeah. All right, let's do cardiac. 16, 3. Just get that page. Okay. All right. Cardiac, we have the 4 chambers with all the heart valves. Remember, I try before I buy stuff, tricuspid and bicuspid valves. It's controlled by the electrical conduction system, which part of that is known as the pacemaker. The SA node, right? The SA node is the pacemaker. Then it goes to the AV node, right? Purkinje fibers, blah, blah, blah. So kind of know those. Let me just look at the different, let's see. So veins carry blood to the heart, arteries carry blood away from the heart. So think of A for away from the heart. For diagnostic examinations, a chest x-ray will show us if the heart is really big. An angiogram, anything you see gram, that means we have x-ray imaging, lots of pictures or a live, like a video using an x-ray machine, and we're going to inject dye to visualize usually the heart or arteries or veins. If we use any kind of contrast dye, we always double check for allergies like iodine or shellfish. And we tell them to drink a lot of water after the procedure to flush out the dye. Cardiac catheterization or angiogram. Remember, this is where they can be, the entrance for these procedures can sometimes be in the lower femoral artery. So we're going to apply afterwards a compression dressing. Make sure that you monitor that and look for bleeding. Okay. Let's see. Looking at the, okay, different types of cardiac dysrhythmias. So there's some, there are some dysrhythmias that have regular rhythm, but irregular rate. Okay? Regular rhythm, irregular rate. The first one is sinus bradycardia. So sinus means normal rhythm, which is bradycardia, which is too slow. This is a pulse of less than 60. Okay. Let's see. Sinus tachycardia is a regular rhythm but rapid rate. This is usually a heartbeat of 100 to 120. SVT is supraventricular tachycardia. This is where the heart rate can be from 150 to 250. This is usually the last thing that happens before heart failure. It could also be because of caffeine, drugs like meth or coke, anxiety, emotional stress. Irregular rate is, or rhythm, is AFib, atrial fibrillation. This is where the atria, instead of pumping and relaxing and pumping and relaxing, they're kind of more like vibrating. So the ventricles are still lub-dub, but the atria are almost quivering. So because it's quivering, it's not quite pushing all the blood through with each pump. So you do have a higher risk of blood clots forming. Patients with AFib usually are on a blood thinner, right? Like warfarin or Xarelto, things like that. This one you can live with because the ventricles are compensating and still pumping the blood back to the lungs and back to the body. They can, so that's why people can live with AFib and even might be asymptomatic to it. AV block. So common causes of AV block are like an MI, heart failure, drugs, hypokalemia. There's different degrees of heart blocks. First degree block, usually there's no symptoms, but it can progress. But the heart rate we see is really low, like 30 to 40 beats. And then if you progress all the way to third degree block, or third degree AV block, they're more than likely going to need a pacemaker. PVCs. So in a normal heart rhythm, the atria contract, and then while they relax, the ventricles contract, right? So it's top, bottom, top, bottom. With PVCs, this is where the ventricles don't wait their turn and they beat prematurely. They beat before the atriums are done relaxing. So it could be different. It could be random. It could happen every second beat, every third beat, every fourth beat. It just depends on what that EKG strip looks like. But because it's not waiting for the full filling of the atria, we're not getting enough blood out. It's not waiting its turn for the atria to fill up and release it into the ventricles. It's just maybe the ventricles maybe only halfway filled before it's pushing out to the lungs or to the body. So these patients can have decreased cardiac output. And remember, when your body's not getting enough oxygenated blood, what does that look like? That looks like palpitations, weakness. You might feel dizzy or lightheaded, maybe even have a headache or faint. We treat this with like carvedilol, propranolol, any kind of anti-dysrhythmic medication to help keep that ventricle in check. VTAC. Now, VTAC, ventricular tachycardia, is where the ventricles have their own rhythm. They're doing their own thing. Okay, they are not waiting for the atria at all. They're on a whole different rhythm. This one can be, usually it's from ischemic heart disease. Now, if they have a stable ventricular tachycardia, we can give them a medication. But if they have a underlying heart disease, they can be put on a beta blocker. But the one that's really deadly is VFib. So remember, AFib, the atrium are like quivering while the ventricles pump. VFib is the opposite. The atrium is pumping and the ventricles are quivering. So if I'm quivering, do you think I'm getting any blood supply out to my body? No, we're not. So this one is a medical emergency. They're going to suddenly collapse because they've suddenly lost blood supply. Those ventricles are just quivering. So this is where we do CPR, BLS, to try to and use the defibrillator to get that ventricle back on track. And then, of course, flatline is cardiac arrest. This is where you don't have it. And you don't defibrillate a cardiac arrest. You have to get some type of movement going on before the defibrillator will work. Any questions on dysrhythmias? Okay. Disorders of the heart. So we have coronary artery disease, or like coronary atherosclerosis or arteriosclerosis is where we got too much gunk lining the artery pipes. Most often it's from cholesterol. There's usually a like a sedentary lifestyle, high-fat diet where the plaque builds up. We've also got angina. This is where patients may experience chest pain every now and then. It comes and goes, most often with activity. Remember, when you get chest pain, it's because your heart muscle is not getting enough oxygen. And it can be because of the narrowing from too much cholesterol buildup. So if I'm walking up a hill and my artery is much narrower than to meet the needs, then I'm going to start to feel that chest pain. Sorry, one second. Okay. Let's see. What is the treatment for angina? It's going to be that nitroglycerin sublingual tablets. Remember, it's 3 doses, 5 minutes apart. Signs and symptoms of angina, knowing it's like that heavy chest. I feel like it's something sitting on my chest, maybe left arm pain, pain radiating into the back, nausea and vomiting, or upset stomach for women. MI is a heart attack. This is where you have death or necrosis of the heart muscle. This is from maybe that buildup of cholesterol finally broke off from the wall of the artery and is completely clogging that artery. Or it's an embolism that's blocking the path, like a foreign object or a blood clot from somewhere. What's the treatment for that? Well, we gotta clear that artery to get blood back to that heart. Heart failure. This is a chronic condition where the heart just over time gets really tired. This can be from many different things like heart disease, a plaque buildup, a lot of stress, uncontrolled blood pressure. Most often, the patients won't feel any symptoms until the left ventricle starts to fail, and that's because the left ventricle is what supplies the rest of the body with oxygenated blood. So remember, when our body doesn't get enough oxygenated blood, we're going to have that fatigue, anxiety, cool skin, feeling restless, short of breath. How do we treat heart failure? We want to try to, of course, reduce any kind of lifestyle risk factors like obesity. If we're smoking, tell them to quit, eating a healthier diet, lower the cholesterol, exercise more frequently. Also, we're probably going to give some medication to help relieve that work or release some of the load on the heart. So if it's high blood pressure, we're going to give them a blood pressure medicine to bring down, relax those arteries. We may give them a medication to help strengthen the heart muscle so it can pump a little bit stronger. Most often, they're probably going to need oxygen therapy because they're just not getting enough oxygen to their body. Their diet should be low in sodium so they don't retain a lot of fluid.
Bless you.
Thank you. And then the next is pulmonary edema. This is where the heart failure has gotten so bad, the fluid or the blood supply that the heart is just too weak to move forward, actually goes back into the lungs. So what does that look like? That looks like the patient might feel like they're drowning. They're really restless, very short of breath. They're breathing more often because they're not getting enough oxygen because those alveoli are underwater with the amount of fluid that's backed up from the heart. And if it's not treated, it could cause respiratory failure. This is a life-threatening condition that needs to be addressed quickly. So that has to do with the heart beats and the heart function. There's other diseases with the valves of the heart. If we have an issue with our valve, it's not closing completely. Remember, it's supposed to open and close those little leaflets. few different things can cause it. First thing is usually like infection. Most common one is the rheumatic heart disease. This is where bacteria enters the bloodstream, travels through the body to the heart, and the bacteria latches onto one of the heart valves and grows on the heart valve, and it becomes more rigid and not being able to open and close as much. How do we know somebody has a rheumatic heart disease? They're going to have a heart murmur. We're going to hear that blood rush back to the atria because that valve is not closing all the way. Well, how do we treat rheumatic fever? Well, or rheumatic heart disease, usually with antibiotics, prophylactic antibiotics. The most common one is penicillin. I have I think he's 14 now, 14-year-old patient that he had rheumatic heart disease diagnosed when they found a heart murmur. And he actually has to get a penicillin shot every month until the age of 20 to prevent heart failure. Complications of rheumatic heart disease could be, well, that bacteria can spread and cause carditis, right? Endocarditis, infection to the heart wall. Okay. Pericarditis, remember, is inflammation of the membranous sac surrounding the heart. This is the outermost layer of the heart. And what does it sound like? What does pericarditis sound like? Remember, this is the pericardial friction rub. Remember, we hear their like pleural, remember that pleural, when the lungs, the outer part of the lungs, it's like the grating sound. We're going to hear the same grating sound when we listen to their heart with pericarditis. And it's very uncomfortable. There's a lot of inflammation. So they're going to complain of fatigue, chest pain, muscle aches. It's very painful. Because of all the inflammation, we're probably going to see a dysrhythmia because it does affect the output of the heart. If it's a bacterial infection, we're going to give them antibiotics and anti-inflammatory so the heart muscle doesn't feel so irritated. Worst case scenario, we may have to do a pericardial fenestration where you have to take out that extra fluid that accumulates from all that inflammation. Think about when you sprain your ankle, right? Your ankle gets lots of fluid around there because of your body's trying to respond and wash away all of those inflammation cells. Infective endocarditis. So this is infection inside the heart. This is the innermost lining of the chambers and the valves in the heart. 90% of all of these cases are usually because of bacteria with strep, staph. Those are very common in a lot of diseases, including strep throat. So it could, worst case scenario, your strep throat infection, if left untreated and it becomes severe, that bacteria can enter through your tonsils to the bloodstream and cause heart infection. Other ways that this can happen is most often IV drug use or bad teeth hygiene. Symptoms are going to be, really high fever, fatigue, right? They're sick. They've got this bacteria in their bloodstream that's gone to their heart. They're really going to talk about flu-like symptoms. They're going to be given antibiotics to kill the bacteria that's causing it. They may need some medication to help them with the output of blood because the heart is just so irritated. And if it causes damage to one of the valves, they may have to replace the valve, either with a pig valve or a mechanical valve. Before, back in the day, endocarditis used to kill people, but now the prognosis is a little bit better now that we have better antibiotics. But you just got to get that patient to the hospital to get treated. Myocarditis. Remember, myocardium is that middle layer of the heart. Myocarditis happens when either an infection of the pericardium, the outer layer, or endocardium, the inner layer, is not treated, and that infection just seeps into the layers and gets to the myocardium. So treatment is, well, whatever is causing that infection to eliminate it. Cardiomyopathy. Cardiomyopathy is when the muscles of the myocardium, the heart muscle, gets weaker and weaker. It's not associated with like coronary artery disease or hypertension. These are just the heart muscle is just so tired. There's different types. There's dilated cardiomyopathy. This is where that ventricle is just so big and that heart muscle wall is so thin, it just doesn't have the strength or the ability to contract all the way and push the blood into the rest of the body. Or you've got the like hypertrophic cardiomyopathy where that muscle wall in that ventricle has gotten so big that it's decreased the amount of blood that can fill in that ventricle. These could be caused from infection. It could be because of nutritional deficits, alcohol, lupus, or cocaine. Most often, cocaine. So what happens? What are we going to see? Just like all the other cardiac stuff, they're going to have decreased cardiac output. So fatigue, dyspnea, feeling dizzy, maybe some chest pain, maybe some passing out. So how do we treat it? Well, we're going to give them medications to help improve the cardiac output and medicines to kind of preserve what function the heart has left. So we're usually like ACE inhibitors, beta blockers, sometimes even an internal defibrillator is placed. Worst case scenario, cardiac transplant. Okay, peripheral vascular disease or disorder. So we're done with the heart. We've gone through all the heart. Now we're going to talk about the rest of the cardiac or vascular system. Let's see. So we've got, okay, peripheral. Okay, so if we don't have enough blood flow going to our extremities, we don't have enough arterial blood flow, what are my legs going to look like? Are they going to be blue or are they going to be pale and shiny?
No blood flow.
Decreased arterial circulation. We don't have enough blood getting to our feet, so we're going to look pale. We're going to have not as much hair, and the skin is going to be shiny because it's not getting enough oxygenated blood. What's common with arterial circulation issues is something called intermittent claudication. This is where pain is worse with activity because we're not meeting the demands of the feet while walking. We're probably also going to have a hard time feeling their pulse, their pedal pulse. You should know the pulse scale, 0, +1, +2, +3, +4. Remember, normal is +3. The mnemonic patches is very helpful when you're assessing either veins or arteries. No, normal is 3 plus. 3 plus is normal strength and quality. 2 is weak. 1 is barely palpable, and 0 is absent. So patches. So in mnemonic patches stands for pulses, appearance, temperature, capillary refill, and like the hardness. So for pulses, we're looking at the arterial blood flow, right? A for appearance, if the extremity is pale, with no hair and it's shiny, that's arterial insufficiency. Now if it's like purple, blue, black, swollen, that's a venous issue. T for temperature and arterial insufficiency, we're going to be cold, right? Because we're not getting enough blood flow there. If it's a venous issue, the foot's going to feel norm or even a little bit warm because the blood is just pooling there. The E is for edema. So pitting edema is usually with a venous issue. We're not getting, the blood is not going back to the heart, it's just pooling at the feet. S is for sensation. Okay, so patients with venous issues might have numbness, tingling. That's better when they move their feet or when they lift their feet. Arterial issues, they're going to feel better with their legs hanging down. Hypertension, normal is 120 over 80, right? Hypertension is more than 140 over 90. Then you've got that like pre-hypertension, right? The 130s over 80s-ish. Hypertension is influenced significantly by our lifestyle, so our weight, salt intake, alcohol intake, smoking, our overall diet, high fat or stress, caffeine or sleep. Medications for hypertension. These are all the ones that you guys went over in pharm. So the ACE and ARBs, they're kind of similar. The diuretics, beta blockers, the calcium channel blockers, all of those. Those medications should be taken in the morning, in addition to all of the lifestyle modifications. What's a complication of uncontrolled hypertension? MI, stroke, aneurysm, and death. Okay. Arterial disorders. This is arteriosclerosis or atherosclerosis. This is where the arterial walls have gotten thicker, either most often because of that plaque buildup, or they lose elasticity. If we have the PAD, the peripheral arterial disease, this is where the arteries in our lower legs have been affected. It can be most often from plaque or cholesterol buildup. These are going to feel better when they put their feet down. Okay. They're going to feel more pain if they put their feet up. If I have poor blood circulation to my feet and I get a wound on my feet, I'm going to have a hard time with it healing because I'm not getting that fresh oxygenated blood to the wound. How do we treat it? Well, we may have to put a bypass graft, right? We may have to put another artery, like artificial artery, bypassing that portion of the artery that's blocked. Most often that's inserted through the femoral artery, right there in the inguinal area, the groin area. Another issue could be an arterial embolism, right? So these are like blood clots or something that's solid and floating through the bloodstream. And where could that go? That could go to the heart and cause an MI or dysrhythmia, heart failure. It could go to the brain and cause a stroke or an aneurysm. How do we treat it? Well, we're going to treat it with quote quote blood thinner and anticoagulant like warfarin, aspirin, Plavix, that kind of stuff. Arterial aneurysm. This is an aneurysm is when the wall of an artery is so weak it bulges like a balloon. And then worst case scenario, it can pop because that line that bulging part is thin and weak. Let's see. The most often aneurysm that I hear about is the abdominal aorta, the one right in the middle of the chest. This is where somebody has sudden, like, chest pain and they just pass out. And you can even start to see the abdomen like pulsating because the blood is just rushing in their abdominal space. This is an emergency if it ruptures. And they need surgery to suture it up. Let's see. Raynaud's disease. Raynaud's disease is when we have intermittent lack of blood flow through the arteries. Usually it's the fingers, the toes, the nose, the ears, the most distal parts of our blood system. I actually saw a girl with Raynaud's 2 weeks ago. The complaint was white fingers when it's cold. And she wasn't able to show me in the office, but I said, did you happen to take a picture of your fingers? And sure enough, her fingers were stark white. So what happens when you cut off blood supply temporarily, your extremity becomes very white. And then when the blood flow returns back, you get that numbness, tingling sensation. It's not a life-threatening disease. It's not caused by a blood clot blocking the flow. For some reason, that arterial wall has a spasm and blocks flow. We have found that if a patient just avoids extreme colds, like wearing mittens, wearing a mask, that kind of stuff, or even stress can cause it. They can control those things. They'll have those flare-ups less often. For venous disorders, thrombophlebitis. This is an inflammation of a vein that can occur with a thrombus, so a blood clot. This can develop into what we all know and heard about many times, a DVT, a deep vein thrombosis. These are a medical emergency because that blood clot can dislodge and travel through the body. If we have a DVT, we're going to give them an anticoagulant so that we can, or a fibrinolytic, so that we can disintegrate it or dissolve that blood clot. Most common places of a blood clot are going to be in the lower leg, usually the calf. Patient is going to complain of extreme calf pain. The calf is going to look really red, really swollen, maybe even be hot to touch. I had a patient the other week that she was hospitalized, came to me as a hospital follow-up. They found a blood clot in her left arm, and what took her to the hospital was because her left arm became all of a sudden way bigger and way more swollen than her right arm. She was put on an anticoagulant afterwards. Let's see. Varicose veins. Varicose veins are those veins that are more superficial to the skin and can cause some discomfort and pain. It's not life-threatening, but it can be like a cosmetic thing for some people, and it cause really achy legs. Treatment for that really good one is either compression stockings, more frequent rest periods where you elevate your legs. But it's not a medical emergency. Venous stasis ulcers. This is where we have not enough blood flow going back to the heart and the blood is just pooling there, and it can create an ulcer. We've got lots of really good looking pictures in your book. So how do we treat it? Well, we need to treat the wound, and we need to try to get as much rich blood as we can there. So that might be, so elevating the foot, if it's on the foot, a high protein diet, and keeping the wound clean. Any questions on cardiac?
Real quick, Miss Sally, so, you said for the murmur, is that only related to for the valves?
Yes.
Okay, that was just a curious question I just had. Okay, sounds good.
Yeah, so a murmur is a backflow of blood through the valves. Now you're thinking maybe of a dysrhythmia where that lub dub is no longer like lub dub. It might be lub dub dub or lub dub 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 or maybe even vibrating.
Mm-hmm.
But that murmur is that whoosh, whoosh, whoosh in between the lub dub. That's a murmur.
Get out.
Okay, good to know.
Yeah, it's hard to explain until you actually hear it on a patient. Then you'll see what I'm talking about.
My friend has it, so I'm going to hear him.
There you go. Go take your stethoscope over there. Yep. Any other questions on cardiac, you guys? I'm so sorry, I forgot how big cardiac was. I'm gonna have to sign off because it's 8:30, but I can do another review maybe on Saturday evening for a little bit to go over the other chapters.
Thank you.
Yeah, all right. You guys have a good night. I'll send out another link for Saturday evening if you guys can join it.
Okay, thank you. Good night.
You guys have a good night. Oh, Leo says good night.
Thank you.